Good evening, everyone. I'm Dr. Sanket Nivale, representing Macleod's Medical Affairs, and I welcome one and all to this scientific platform provided by Macleod's Pharmaceuticals. Today, we have with us an interesting speaker, person, doctor, who have done his research in cardiology, has special interest in cardiology, and would be talking more on a very elegant topic tonight, which is basically talking about cardiology and centrally acting drugs. Before I hand over the session to him, I would like to introduce him, Dr. Amit Sinkar. He is a consultant cardiologist. He has done his DNB cardiology in 2010 from NM Vadia Institute of Cardiology in Pune. He has done his DNB medicine in 2005 from MMF's Joshi Hospital in Pune. He has done his MBBS from 2000 from KJ Somaya Medical College, Mumbai. In his professional experience, he has been at Sri Sai Baba Heart Care Institute and Research Center at Nasik, being a full-time cardiologist between Jan 2012 till December 2012. Performed more than 1,000 angiograms independently and assisted more than 200 angioplasties in 1 year. Worked as an independent cardiologist for the last 7 years and attached to prestigious institutes in Pune like Rasiklal Dhariwal Heart Center, Heart Care Center, NM Wadia Institute of Cardiology, MMF Joshi Hospital, Ratna Hospital, and Navalmal Firodia Hospital, MJM Hospital, Oyster and Pearl Hospital, Deccan Hardikar Multi-Speciality Hospital, and as consultant cardiologist. Manages non-invasive and limited invasive cardiology procedures independently. He has started his own clinic called as the Sinkar Cardiac Care at Ghole Road, Pune, from January 2018. With this, I would like to hand over the session to Dr. Amit Sinkar and let us get enlightened on the topic centrally acting drugs like moxonidine in resistant hypertension. Over to you, sir.
Yeah, thank you, Dr. Nevale and McLeod's company for inviting me as a speaker on this forum. Incidentally, my thesis topic for DNB medicine was on clonidine, though it was not in hypertension, but I had used clonidine quite regularly in alcohol withdrawal syndrome actually. So I'm used to using centrally acting drugs for a long time. Of course, at that time, moxonidine was not freely available. So that's why I had used clonidine quite well. So coming to our today's topic, even though this is not a regular molecule, but it is a very important molecule when especially we are looking at renal failure patients or resistant hypertension patients. So I'll just start sharing my screen and we'll come to the lecture. So we'll start with discussion on resistant hypertension and then slowly we'll move on to centrally acting antihypertensives including moxonidine along with its evidence in real world. So hypertension, paradoxically, it is the most easiest risk factor to be diagnosed, but often remains undetected. We all know that 50% of the hypertensives are not aware about their hypertension when they are first diagnosed. And though it can be controlled very easily, it often remains untreated. And despite availability of potent drugs, the treatment is often ineffective. So that's why hypertension is the largest silent killer, because though we have all the tools to diagnose and treat, it is the most undertreated and underrepresented risk factor. HOT and UKPDS trials have shown that aggressive pharmacological treatment of moderate and even mild hypertension leads to better survival and lesser cardiovascular morbidity. To the extent that few trials have shown that even 2 millimeters reduction in reduction of blood pressure in the long run will definitely make a difference in the reduction of adverse events. Effective and long-term control of blood pressure to less than 140/90 can reduce stroke by nearly 40%, myocardial infarction by almost 25%, and heart failure by more than 50%. If you look at the conventional treatment in younger versus older individuals, Usually, the step one is to start ACE inhibitor or ARB along with or beta blocker alone in the younger individuals. And in older patients, we tend to start with a calcium channel blocker or a diuretic as the first drug of choice. Step two, we combine one from both the groups. Step three is usually A or B plus calcium channel blocker plus a diuretic. So step four, wherein the three antihypertensive drugs are already started, including a diuretic, and despite that, if the blood pressure is not at target, that's when we call the patient as resistant hypertension. And here comes the stage where we either add an alpha blocker or spironolactone or other diuretic. So what are the limitations of present therapy? In spite of using drugs from all the above classes, either as monotherapy or in combinations, hypertension still remains uncontrolled. Now, trials have shown that still almost 40% of the patients are not under optimal control despite giving them the optimal guideline directed medications. It may be either due to poor adherence or sometimes it can be due to inadequate treatment regimen from our perspective. In addition, all the classes of antihypertensive drugs have adverse effects on their own, which increases in combination therapy further. So, resistant hypertension, it is usually resistant to conventional medical therapy despite intake of three or more antihypertensive drugs, including a diuretic. And the resistance is usually defined by numbers as blood pressure of more than 140 by 90 in patients less than 60 years, or in those above 60 years, the target is slightly lenient to more than 160 by 90. Epidemiologically, even though the prevalence is unknown, but observational and clinical trials suggest that it is a very common clinical problem. In a recent analysis of the HINS participants being treated for hypertension, it was found that only 53% were controlled to less than 140/90. And if you look at the subsets of other comorbidities, in CKD patients, only 37% were controlled to optimal target of less than 130 or 80, and only 25% of diabetic patients were controlled to the optimal levels of less than 130 by 85. So almost 1 in 4 diabetics are only controlled and 3 out of 4 diabetics have uncontrolled hypertension, which further increases the risk of adverse cardiovascular events. In the ALAT trial, for approximately 5 years of follow-up, only 27% of participants were 3 or more medications. The etiology of resistant hypertension could be multifactorial. It could be because of either suboptimal therapy, where we tend to not go to the highest possible dosages of a particular antihypertensive, or we don't combine them in optimal ways, or there could be extracellular volume expansion. If the patient has been consuming a lot of salt or sodium based foods, then that may lead to extracellular volume expansion, which may lead to uncontrolled hypertension. Or there could be poor compliance with either medical or dietary therapy. Secondary hypertension is one reason which is often overlooked, and that may be the reason for second resistant hypertension. It can also be office or white coat hypertension, which constitutes almost in 10% of pseudo resistant hypertension, I would say. Pseudo hypertension is one reason where blood pressure is always high in the office, but unless and until you document it on a ambulatory BP monitoring system, we won't be actually able to differentiate between white coat versus really true hypertension. Sometimes there could be history of ingestion of substances like illicit drugs that can elevate blood pressure, or even certain medications could be responsible for increase in blood pressure. The commonest being usage of nasal drops, which are used as nasal decongestants. Even they are responsible for resistant hypertension, and the moment you stop the usage of these nasal decongestants, the BP normalizes immediately. It could be also related to side effects on many antihypertensive drugs that lead to stoppage of the antihypertensive medications, and not always the patients do tell the doctors that they have actually stopped the medications because of these side effects. Now, suboptimal therapy means the most common and mostly correctable cause of resistant hypertension is suboptimal therapy. Adequate trial of maximally tolerated dosages of at least 3 drugs and sequential monotherapy with 3 drugs of different classes is not adequate. We need to start on a combination as early as possible. Failure to prevent volume expansion with adequate diuretic therapy. So that's why it is recommended even today that diuretics should be, especially the thiazide group of diuretics, should be the first line of drug, which will help in optimizing the volume status. And that's why the guidelines recommend that one of the antihypertensives should always be a diuretic. Once the creatinine clearance falls to below 30, a loop diuretic should be substituted for a thiazide diuretic. About the extracellular volume expansion, most patients has relative or absolute extracellular volume expansion, and the underlying conditions could be renal insufficiency, sodium retention due to vasodilators. It could be ingestion of high salt diet, presence of clinically occult expansion, and use of once daily short acting loop diuretics. So gradual removal of fluid is necessary for the BP control. Sudden decongestion or sudden removal of fluid may lead to dehydration. It may paradoxically activate the RAS system and actually lead to more volume expansion, leading to further uncontrolled blood pressure. Regarding poor compliance, up to 80% are at least partially non-compliant. So for that, we need to have various ways to ascertain the compliance of the patients. Lack of knowledge about the disease and relative absence of symptoms is another reason for pseudo-resistance or true resistance of blood pressure. That's why we need to always engage our patients, educate them about the disease, and keep engaging them in their day-to-day management of hypertension. Sometimes the cost of the medications is too high. We usually tend to neglect the cost of the medication that we are prescribing. So in fact, we should be keeping a list of the total cost of the medication that our patients are taking. That will also tell us whatever we are prescribing, whether it is pocket friendly to the patient, and accordingly, if necessary, you can either substitute the brands or substitute the medications if necessary, so that makes it more affordable to the patient, and the compliance of the medications could be ascertained very well. Or sometimes there are complex dosing schedules which the patient is unable to remember, especially the elderly people or who are dependent people. They may not remember the complex dosing schedules. So in that case, either keeping an attendant or giving them phone calls to make them aware of their dosing schedules may help. So what are the checkpoints that we need to look at to adhere to this compliance issue? Patient education is foremost. We should educate them about not only the disease, but also about the medications that they are taking, what could be the possible side effects, how are they supposed to adjust their medications depending upon side effects, rescheduling the missed appointments, monitoring of drug-induced side effects, simplifying the drug regimen, monitoring of drug intake, pill counts, asking them to bring their empty strips for during each visit and actually count whether they have already consumed their regular dosages, physiologic changes after medication, and also educate them to monitor their own pulse rate, especially if they are on beta blockers, so that any reduction in heart rates can be reported at the appropriate stage, so that any complications or side effects of beta blockers could be prevented. Coming to lifestyle modification, obesity, low salt diet, and alcohol intake. The alcohol intake can be limited to 1 ounce of ethanol, especially depending upon the type of alcohol that they are consuming. It can be restricted to moderation. Also need to look at secondary hypertension, wherein up to 11% of patients with refractory hypertension have actually an identifiable secondary cause. And the most common of them, or which are being missed, are renal artery stenosis and chronic renal parenchymal disease. And for that, a simple ultrasound abdomen for kidneys or a renal artery Doppler may be sufficient to give us a possible diagnosis of this particular cause. Coming to renovascular hypertension, when previously well-controlled hypertension has recently become resistant to therapy, or patients older than 50 years of age with evidence of generalized vascular disease should be examined for renovascular disease. So even though patients may not have renal issues previously or at the onset of hypertension, but eventually they may develop renovascular disease, and then the blood pressure may start going out of control. So that is when we should suspect an onset of renovascular disease. Captopril-induced renograms are useful for this purpose. unless the serum creatinine level is higher than 2 milligrams per deciliter. Doppler imaging is the most commonest test for the renal arteries, and it has recently been shown to be sensitive in detecting radiologically confirmed renal artery stenosis in patients with arteriosclerotic renal disease. Then another cause for secondary hypertension is primary aldosteronism. Up to 5% of patients with refractory hypertension do suffer from this disease. The aldosterone-renin ratio is useful when screening for primary aldosteronism, where we need to monitor the serum levels of aldosterone as well as renin. And to add that, we may just do a simple serum electrolytes test, wherein the sodium and potassium levels could guide us about the possibility of this particular cause. Regardless of whether patients have an adrenal adenoma or idiopathic aldosteronism, they respond to aldosterone antagonist very well. So that's the reason the guidelines now recommend usage of aldosterone antagonist like spironolactone as a fourth line of drug, especially in initial stages of resistant hypertension. Pheochromocytoma is another cause for secondary hypertension, which is usually missed out. And tests for urine metanephrines and/or catecholamines are used to screen for pheochromocytoma. The HPLC quantification of metanephrines is used if there is any doubt about the specificity, and endocrinologic evidence should be confirmed before proceeding to more expensive imaging techniques. So look for the history, look for any physical signs which may guide us towards possibility of pheochromocytoma, then screen them for urine metanophrines, and then only subject them to higher radiological abnormalities like a CT or MRI scan. Office or white coat hypertension is the commonest and the easiest way to rule out pseudo-resistant hypertension. So most patients are anxious, and when visiting the physician, there is an acute rise in blood pressure in almost 20 to 30% of patients. Now that can be minimized by having a nurse or a technician take the pressure rather than the physician himself. And also look for development of hypotensive symptoms like weakness or dizziness on a variety of different antihypertensive medications, because they are not true hypertensives, and you start them on antihypertensive medications looking at the office blood pressure, and actually when they go home or back to their own routine, their blood pressure being normal, the usage of antihypertensive medications may lead to hypotension and symptoms of weakness and dizziness. Other ways to ask them to relax for 15 minutes before you actually check the blood pressure. Nowadays, automated digital blood pressure apparatuses are being used, wherein the patient can be made to sit quietly, relax in a quiet room for 15 minutes. He monitors the blood pressure on himself by the automated BP reading, and usually the first reading is neglected and the average of second and third reading is taken as the actual blood pressure. So that also can help in minimizing the white coat effect of hypertension. 24 hours ambulatory BP monitoring gives us a more better idea about true hypertension versus white coat hypertension. The definition being normal blood pressure at work or home, and refractory office hypertension without any end organ damage such as left ventricular hypertrophy on ECG or echo. And in fact, there are symptoms of hypoperfusion despite persistent hypertension, meaning the patient complains of weakness and giddiness at home, but always the clinic blood pressure is found to be high. The prognostic value is also high with 24 hours BP monitoring. Refractory hypertension is defined as, despite therapy with more than 3 drugs, including a diuretic, the diastolic blood pressure, if it is more than 100 on a 24 hours BP monitoring, then the mean 24 hours diastolic BP versus the cardiovascular events over a median of 49 months, if it is found to be more than 97 millimeters of mercury, it carries a poor prognosis. Pseudohypertension is defined as, especially it is found in older patients when there is thickened and calcified arteries, and when we conventionally monitor it with external sphygmomanometer, then because of the calcified arteries, the blood pressure is falsely found to be on the higher side, and compression of the brachial artery with the sphygmomanometer requires a cuff pressure which is greater than is present within the artery. And the systolic and the diastolic blood pressure estimated from the BP apparatus may be more than 10 to 15 millimeters of the actual value, than which can be measured by directly through a intra-arterial pressure monitor. So if you find a very elderly patient, like an 80-year-old whose blood pressure is always above the limits, then it is always necessary to keep the possibility of pseudo hypertension. The only way to find out whether it is pseudo hypertension or no is directly or optimally through intra-arterial pressure. But clinically, you can suspect if you can palpate the artery even in diastole, and you can actually roll the radial artery in between your fingers uh, despite systolic or diastolic phase of the heart. So factors related to the physician wherein the potential causes of pseudo-resistant hypertension could be present are improper blood pressure measurement, use of inappropriate antihypertensive medication, inadequate dosages, inappropriate combinations of medications, or physician inertia, that is failure to change or increase the dose regimens when not at goal blood pressure, or poor communication between doctor and patient, or complicated therapeutic plan, especially in the presence of multiple concomitant medications or complicated dosing schedules of antihypertensive drugs. Now, a commonest mistake that we often see is inappropriate cuff size that we use. We tend to use the same cuff for all builds of patients, and there are specific guidelines what should be the arm circumference of the cuff. If it's an obese patient, we need to use an appropriate cuff. If it's a thin build patient, we need to use a smaller cuff. So using a proper size cuff itself can lead to appropriate diagnosis of blood pressure and rule out these pseudo-resistant hypertension issues. Factors related to patient could be white coat effect, drug-related side effects, low commitment from patient side, inadequate patient education, concomitant use of oral contraceptives, which the female patients usually tend to hide from the physicians. So we need to specifically ask in reproductive age group patients whether has been any use of oral contraceptives, concomitant use of anti-inflammatory or sympathomimetic agents, chronic use of steroids, memory or psychiatric problems and cognitive disorders, especially in elderly subjects, and cost of medication in some healthcare systems. So we need to actually document each one of these factors when we are looking at resistant hypertension patients. Other causes could be obstructive sleep apnea syndrome. This is another commonly missed symptom or sign. The simple history that we need to ask these patients is about snoring. And you may find that more than 50% of the patients coming with resistant hypertension do complain or give a history of snoring. And if you do a sleep study in these patients, many patients could be diagnosed with obstructive sleep apnea syndrome. And with just usage of regular CPAP machine at night, would make them get rid of their antihypertensive medications and correct their blood pressure to normal levels. Chronic kidney disease could be another reason. As we discussed in the secondary causes, it could be hyperaldosteronism as well, or it could be just the pseudo hypertension because of the calcification of arteries. And lastly, aortic wall sclerosis with hemodynamically significant insufficiency, that is aortic regurgitation, may give rise to falsely elevated systolic pressure. But in these patients, the diastolic pressure is too low and there is a very high pulse pressure. So isolated systolic hypertension, but with a very high pulse pressure, we need to rule out possibility of aortic regurgitation as well. These are the various mechanisms by which various factors could be responsible for resistant hypertension, and the reasons being usage of NSAIDs or glucocorticoids or mineralocorticoids, usage of cyclosporin, usage of erythropoiesis stimulating agents, especially in renal failure patients, and illicit substance abuse, like the patient may be consuming cocaine. We need to directly ask them such kind of history, or any other kind of illicit drugs may be responsible for hypertension. Sympathetic overactivity, whenever we are looking at treatment of hypertension, we should try and focus what could be the possible mechanism of hypertension, because unless and until you try and find out the exact pathophysiological mechanism of this particular patient, the choice of drug may be wrong, and we keep on giving a different pathophysiology mechanism medication, and the patients continue to have high blood pressure, and that leads to increasing dosages of unwanted medication leading to more side effects. So initially during the history, if we can pinpoint the appropriate mechanism and use the appropriate drug, that will help in controlling the blood pressure appropriately at the right stage itself. So sympathetic overactivity is one of the mechanisms. It may be a central feature linking hypertension with other components of metabolic syndrome as well, which could be diabetes, which could be insulin resistance, which could be obesity, and all these may lead to renal disease, dyslipidemia, and hypertension altogether. So in animal models, sympathetic overactivity can initiate and maintain elevated blood pressure. In humans also, plasma norepinephrine levels in hypertensive patients are significantly higher than in normotensive controls. And sympathetic activation is seen in early phases of hypertension and may precede blood pressure elevation in some patients. It can be high in younger subjects with borderline hypertension. It itself suggests that increased sympathetic activity is the cause rather than consequence of blood pressure elevation. Raised BMI is also associated with an increased rate of sympathetic nerve discharge in skeletal muscles. So there is a definite correlation between BMI, body fat distribution, and urinary norepinephrine excretion. It's linked with insulin resistance and diabetes, also very well proven. Sympathetic activation is a major component of insulin resistance in clinical experience and even in humans with type 2 diabetes. Cardiac autonomic dysfunction occurs in 30 to 50% of patients with diabetes and 40% of obese patients without diabetes. There has also been a link with other risk factors like renal disease, left ventricular hypertrophy, and congestive heart failure, where there is sympathetic overactivity further leading to more and more hypertension. Now, if you want to diagnose true or resistant hypertension, this is the flow chart that should be followed. It is a very simple chart. If you find that the blood pressure is more than 140 by 90 in hypertensive patients receiving at least 3 antihypertensive drugs, including a diuretic, at adequate full dosages, then first look at any discrepancies among office, home, and 24 hours ambulatory BP measurements. So always the first task is to appropriately measure the blood pressure. Then if there is a normal home and high clinic and ambulatory BP levels, then it is obviously office resistant hypertension or a white coat hypertension, and the patient need not be given any additional advices. If there is a normal home ambulatory BP and high clinic BP levels, it is a pseudo resistant hypertension. If all the blood pressure are above limits, then check patient's adherence to antihypertensive drug prescriptions. If that is also appropriate, check the patient's assumption of any interfering drug or substance. After that, identify and treat possible causes of secondary hypertension and any concomitant condition that may persistently keep the blood pressure levels elevated. And after that, optimize and titrate the pharmacologic as well as non-pharmacological therapies. So non-pharmacological advices or therapies has an equal importance along with the pharmacological medications even in resistant hypertension. And if everything is found to be okay despite that the BP seems to be above levels, then it's always better to refer the patient to a tertiary hypertension center where further evaluation could be done. So treatment strategy, autonomic dysfunction appears to have an important role in many patients with metabolic syndrome. Treatment of patients with hypertension should take account of associated metabolic conditions as well. We need to look at the other risk factors, comorbid risk factors need to be treated equally as most of these things go hand in hand, and correction of one factor may lead to improvement in the other as well. The therapeutic objectives are given the adverse effects of sympathetic overactivity and the development of complications. Reducing sympathetic overactivity should be the primary goal of non-pharmacological as well as pharmacological therapeutic strategies in treatment of uncontrolled hypertension. The central sympathetic outflow is carried out through the hypothalamus and the brainstem, which controls the SNS activity, and any stressful stimuli are transmitted from the sensory cortex to the hypothalamus and finally to the rostral ventrolateral medulla. It is the final common pathway for a number of descending influences of the sympathetic activity in response to stimuli. For example, any kind of stress, hypotension, exercise, pain, etc. Now, if there is a selective blockade of this SNS outflow at the medulla level, that will prevent the deleterious effects of sympathetic overactivity. And stimulation of alpha-2 adrenergic receptors and the I1 receptors in this medulla will definitely reduce the central sympathetic outflow. So let's come to the central sympatholytics. Which drugs can help us in achieving this effect? Now, these drugs reduce hypertension by blocking the central sympathetic outflow. The first generation, which are preferentially the alpha-2 agonists, are clonidine, guaifenesin, and methyl-dopa. Out of these, methyl-dopa is commonly used in pregnant patients. And the second generation, which are preferentially the I1 agonists, are the newer drugs like moxonidine and rilmenidine. Now, alpha-2 receptor stimulation and sedation. So what do the first generation have bad in them? These first generation central sympatholytics reduce the central sympathetic outflow by stimulating alpha-2 adrenergic receptors in the medulla. But they also stimulate the alpha-2 receptors at adjoining locus coeruleus and cause sedation. Other side effects are also dizziness, lightheadedness, drowsiness, dry mouth, constipation, and because of these side effects, the patients tend to stop these drugs, which leads to rebound hypertension. Now, if you look at the I1 receptor agonists, that is the imidazoline I1 receptor agonists, which are the second generation alpha-2 blockers, drugs which selectively stimulate I1 receptors in the medulla, they also reduce the central sympathetic outflow without causing the side effects of sedation, which is usually achieved by the usage of moxonidine. Now coming to moxonidine, it is a 200-fold more selective for the I1 receptors than for the alpha-2 receptors, whereas clonidine is a non-selective agonist of both alpha-2 and alpha-1 receptors. Moxonidine preferentially stimulates I1 receptors present in the medulla, and it decreases the central sympathetic tone, causing a decrease in the systemic vascular resistance and thus leading to reduction in blood pressure. So it has a role on sympathetic nerve activity even in renal failure patients as a monotherapy comparison with other antihypertensives, or as a combination therapy. It can be used in either ways, and it has also a role in obese, elderly uncontrolled hypertensives, and at the same time it also has its own pleiotropic effects. Now, even in ESRD patients, it has been shown that as compared to placebo, it does reduce the sympathetic nerve activity significantly, and which will help in reducing the blood pressure significantly. So let's skip this slide. Just to conclude, even in ESRD patients, low-dose moxonidine produced sustained as well as substantial reductions in sympathetic outflow and without any hemodynamic compromise in these ESRD patients. As a monotherapy, there was an 8 weeks trial. It showed that there was significant reduction in the sitting systolic as well as diastolic blood pressure in double digits, more than 10 millimeters reduction as compared to placebo. In elderly hypertensives, when it can be given as an add-on treatment in elderly patients whose hypertension is poorly controlled, despite treatment with 2 or 3 antihypertensive agents, moxonidine could be given safely without any adverse effects even in elderly people. It controls BP effectively even in elderly resistant hypertensives with 24-hour BP reductions in systolic pressure by almost 14 millimeters and diastolic blood pressure by 7 millimeters of mercury. And even in the nighttime, blood pressure was shown to be lesser, both systolic as well as diastolic, with moxonidine. So to conclude, it is an effective and well tolerated when used alone or in combination with amlodipine in the management of essential hypertension. This was the study called as TOPIC study, which showed its use either singly or along with amlodipine in essential hypertension. There was another study called as CAMA study, which was a post-marketing study, and it concluded that moxonidine effectively reduces blood pressure in patients with metabolic syndrome while simultaneously reducing body weight in obese patients. Another study showed that it is a useful and safe drug in controlling arterial hypertension even in obese patients. So various studies were conducted worldwide wherein moxonidine was either compared to placebo in monotherapy, or it was given singly or in combination with other medications in various subsets. And in many subsets, it was found that there were no side effects and the blood pressure could be significantly reduced as compared to placebo alone. Even in obese uncontrolled hypertensives, there was a significant reduction in systolic BP by 23 and a diastolic BP of 13 millimeters of mercury. In suppressing obesity-related hypertension, the mechanism that is being speculated is that moxonidine inhibits the sympathetic nervous system outflow from the brain and counters the primary pathophysiology of hypertension in the obese. And inhibition of sympathetic outflow to the skeletal muscle blood vessels increases the insulin sensitivity, thus improving the metabolic profile of the patient and also leads to reduction in obesity. In iprosartan treated patients in renal failure also, it was found that it is effective as an add-on therapy to ARBs, not only in controlling blood pressure, but also in reducing microalbuminuria by 24%. As compared to clonidine, it was shown that moxonidine is very safe and there was no rebound hypertension as was seen after stopping clonidine. So this was the graph which showed that after withdrawal of the drug, there was sudden blood pressure rise within 24 hours with clonidine, but in case of moxonidine, it was a gradual increase over 3 days, and the sudden increase in blood pressure could be prevented in moxonidine, thus leading to reduction in the adverse events, which was responsible in patients with sudden BP rise or sudden rebound hypertension. Again, this is a slide which shows that even with iprosartan, moxonidine controls the SNS overactivity caused by the angiotensin II mediated as well as independent mechanisms, and it could reduce blood pressure, even the arterial levels of blood pressure and the sympathetic activity. It is also a safe and effective antihypertensive with considerably improved tolerability compared with other centrally acting sympatholytics. So in obese and metabolic syndrome, it was shown to correct the endothelial dysfunction also, and because of these pleiotropic effects, it was shown to halt the progression of cardiovascular disorders as well as the other risk factors like diabetes or dyslipidemia or insulin sensitivity. This was again the study which showed the improvement in GFR levels and improvement in renal function with moxonidine as against which was not seen with clonidine. If we compare it with enalapril, it also showed that it was effective and well-tolerated antihypertensive, as good as other agents like enalapril, with a trough to peak ratio of 0.74, which is a very good ratio. So if you look at a 24-hour reduction in blood pressure, again it was a double-digit BP reduction of 16/10 and 16/11 as compared to enalapril. If you compare it with nifedipine sustained release 20 milligram, in this case also moxonidine was shown to be effective and well-tolerated antihypertensive without the side effects related to nifedipine, and almost 78% of patients achieved the target BP role, which was a very good control as against nifedipine. The reduction in mean blood pressure was also significant of almost 27.8%, which was seen in nifedipine versus 23.8% in moxonidine, and almost similar in the diastolic blood pressure as well. Even when it was compared to nitranedipine, the results showed that it is shown to reduce the number of new ESRD cases by as high as 81% and increase the life years lived by their patients by 0.04. When compared to other antihypertensives, it showed that there was 81% reduction in the ESRD cases by use of moxonidine. So this was purely because of better blood pressure control, especially in the resistant hypertension patients. And when the BP was controlled optimally, obviously the ESRD ratio dropped down in these renal failure patients. If you look at the pleiotropic effects of moxonidine, it was statistically superior to metformin in reducing the insulin concentrations after a glucose challenge. In insulin-resistant patients, it improves insulin sensitivity by 11%. In obese hypertensives, there was 45% reduction in plasma insulin levels, there was 23% reduction in fasting insulin, and also 17% reduction in plasma leptin levels. So all these helped in improving the obesity as well as the glucose tolerance levels in these patients. There were some Indian clinical trials which were conducted at two places, basically at Indore and Mumbai, and it showed that moxonidine could be used safely and effectively in hypertensive patients as compared to ramipril and losartan. The moxonidine treatment offered significant reduction in blood pressure as compared to the conventional drugs like ramipril or losartan. Let's keep the pharmacokinetic component of this particular drug. let's directly go to the indications. Now, where do we actually use moxonidine? It can be safely used in mild to moderate essential hypertension patients also, or it can be used in resistant hypertension associated especially with obesity, which is a part of metabolic syndrome, or in diabetic patients, or even in chronic renal failure patients. Looking at the dosages, moxonidine, the starting dose is usually zero point 0.2 or zero point 0.3 milligram once daily, and it may be increased at every 3 weeks interval, reaching a maximum dose of zero point 0.6 milligram per day in two divided doses. Uh, Sometimes it can be given in thrice a dose, even though it's a off-label dosage pattern, but giving zero point 0.2 milligram thrice a day rather than zero point 0.3 milligram twice a day sometimes helps in reducing the side effects like dizziness or fatigue problems may be reduced by distributing the dose more equally. A single dose should never exceed zero point 0.4 milligram. It is not proven to be safe in pregnancy and lactation and hence should be avoided because of inadequate data. In elderly people, the UC is increased by approximately 50%, and hence lower dosages of moxonidine should be used in elderly people. In renal failure patients with mild to moderate renal dysfunction, that is a GFR of 30 to 60, a single dose should not exceed zero point 0.2 milligram and not more than zero point 0.4 milligram per day should be given. In children less than 16 years, it is yet not to be used because not studied again. In chronic renal failure with GFR of less than 30 ml, the influence of renal function on pharmacokinetics of moxonidine, there was a trial which concluded that in patients with renal failure, the dosage of moxonidine should be individually titrated for the desired clinical response. At the same time, looking at the side effect profile, there shouldn't be any compliance related issue with the molecule. So it needs to be tailor made and optimally and very closely monitored in such patients. What are the precautions that need to be followed while prescribing moxonidine? The cessation of combination with beta blockers. The beta blockers should be stopped first and then moxonidine stopped after a few days. Otherwise, there will be a rebound tachycardia and rebound hypertension in these patients. It should be used in caution in patients with a history of angioneurotic edema with severe coronary artery disease and even in unstable angina. Because if the molecule is stopped abruptly or by mistake by the patients, there could be rebound tachycardia and that may worsen these patients of coronary artery disease leading to an adverse event. So it should be used with caution and the patient should be clearly instructed on not to stop the drug abruptly without consulting their physician. In moderate renal impairment, the single dose should not exceed zero point 0.2 milligram and the daily dose should not exceed zero point 0.4 milligram of moxonidine. What are the advantages of moxonidine? The antihypertensive efficacy is comparable to other classes of antihypertensive drugs as we saw in various trials. It improves the metabolic profile of patients with hypertension as well as diabetes mellitus or impaired glucose tolerance. It is very useful in patients with metabolic syndrome. The antihypertensive effect lasts for at least 24 hours and hence it could be administered once daily dose as well. It is a safe and well tolerated and less potential for any drug interaction, and it is also safe and effective in combination therapy. So we have this Moxovas as moxonidine by our McLeod's company, and with that I end my lecture and let's open this forum for a discussion. So over to you, Dr. Nevle. You can take any questions if at all there are any.
Perfect, sir. Thank you, sir, for the wonderful session. I am sure with the evidence that you shared, along with the vast experience that you shared with us, will definitely help the listeners in managing patients with resistant hypertension and have better patient outcomes. A few questions that have been in the box. Something which goes like being a centrally acting antihypertensive, moxonidine reduces sympathetic outflow. Is anxiety related a sign for the use of moxonidine? I
Uh,
believe this question is all about anxiety and sympathetic outflow and how do you identify it, sir?
Personally, I feel that such kind of patients should be given non-pharmacological advices very clearly. management of anxiety by non-pharmacological ways is much better than just prescribing medications. Even though, despite non-pharmacological measures, if the anxiety persists and if you feel that hypertension is related to anxiety, if it's a younger patient, I would in fact prefer a beta blocker first. And despite beta blocker, if the blood pressure is still not under control, then we may try giving moxonidine as a central sympatholytic, especially if there is side effect to the conventional antihypertensive medications. But as we discussed in one of the slides, we should clearly tell them that while cessation of combination of beta blocker and moxonidine, the beta blocker should be withdrawn first, and then after a while, if needed, moxonidine can be withdrawn, because eventually once the anxiety is controlled, they may not need these antihypertensive medications over a longer period of time. So it's not that they may need it lifelong. After appropriate anxiety control, these medications can be withdrawn safely.
Perfect, sir. Thank you for that, sir. The next question that I see is, what is your experience in using moxonidine early in the therapy of controlling blood pressure?
As discussed, it is not a first line drug to be used in treatment of hypertension. So if we are talking about resistant hypertension in these kind of patients, if the patients are not being controlled despite using 3 antihypertensives, include a diuretic, and if you feel that some increased central sympathetic overactivity could be the reason for this resistant hypertension, then definitely use of moxonidine do help. And I have, in my experience, found very good results of moxonidine, especially in the renal failure patients, where the central sympathetic activity is very high, and usage of moxonidine in these patients definitely reduces the blood pressure to optimal levels.
Perfect, sir. Sir, doctor wants to ask your approach for a patient who has reached you with uncontrolled blood pressure with 3 optimally used class of drugs. I'm sure it's the same resistant
Yes.
diagnosed hypertension.
As we discussed in the slides, there is a protocol which needs to be followed while approaching the resistant hypertension patients. So we need to document each and every step of evaluation of this resistant hypertension, including the compliance issues, including inadequate treatment, including use of associated drugs or an illicit drug use, or try to look at the mechanism of hypertension in these patients. And once you get answers to all these things, and if you find that everything is normal in these patients, then only maybe you should start increasing or optimizing the drugs, and maybe add a centrally acting drug like moxonidine to these patients. But if you find any inadequacy in your protocol or in your checklist, it is obviously instructed to correct those abnormalities first, and most of the times correcting them would lead to optimal control of blood pressure.
Perfect, sir. So with this, I would officially close the session. I thank you, sir, for the wonderful and enlightening session on the topic resistant hypertension and and moxonidine in its placement. I'm sure the listeners would have gained deep insights in managing a patient better using the learnings from your session, sir.
Yeah,
We
thank you
at
so much.
McLeod's would like to honor your vast experience and your kind heart to share the same on our platform for the benefit of all the current and the future listeners. As this is on YouTube, anyone who wants to go through the lecture again can go and check in YouTube, and there would be this session played for them. So also to the current listeners, to the people who are already listening today's session, so to acknowledge them, I would take this opportunity to thank each and every participant attendee who has taken time out from the busy schedule and have respected our invitation to be a part of this scientific feast. I, Dr. Sanket Nevale, representing medical team at McLeod's Pharmaceuticals, on behalf of the marketing and sales team, I thank you for supporting us in this scientific endeavor. Have a great day ahead, sir. Thank you.
Thank you so much. Good day.
Good day, sir.
So thank you